Hello, my name is Jamie Jordan, and on behalf of all my co-authors, I would like to present our research abstract, Development of a Scoring Rubric for Medical Education Research Abstracts Reporting Qualitative Data. We do not have any financial conflicts of interest to disclose, but we would like to acknowledge that this project originated with an SAEM Education Committee objective, and we would like to extend a big thanks to all the committee members who helped support this work. So the submission of education research abstracts reporting qualitative data continues to increase at national emergency medicine conferences. However, there is no standard tool to judge the quality of these abstract submissions. So our objective was to develop a scoring rubric to assess qualitative medical education research abstracts. We used a modified Delphi method to achieve expert consensus for scoring rubric items. Our Delphi panel consisted of 8 emergency medicine education researchers from diverse regions across the U.S. All panelists serve as reviewers for medical education journals, and 4 hold editorial positions. So our study team drafted initial items for the scoring rubric after review of the literature and existing research abstract scoring rubrics to optimize content validity. We then sent these draft items for review and feedback to all members of the SAM Education Committee to gather stakeholder feedback and for further content and response process validity evidence. One author who is not a member of the Delphi panel then revised the initial items to create the initial Delphi survey. Experts rated item importance on a 1 to 9 scale. We had decided a priori that items with a mean score of 7 or greater would advance to the next round, and then items with a mean score of 3 or below would be eliminated. Items with intermediate scores were left to the discretion of the Delphi moderator with the aim of both adhering to the opinions of the experts and creating a comprehensive scoring rubric. Modifications to the rubric were made between rounds based on item scores and feedback from the expert panel. After consensus was achieved, the resulting scoring rubric was piloted by 5 raters on 10 qualitative medical education research abstracts from the AEM, AEM-ENT Critical Appraisal of Emergency Medicine Education Research series. So for analysis, we calculated and reported descriptive statistics for item scores during Delphi rounds, and we used Chromebox Alpha to assess homogeneity of ratings in the Delphi process and considered increasing homogeneity to be an indication of consensus among the expert panel. During piloting, we used interclass correlation coefficient estimates to assess reliability among raters. Now on to our results. So 3 Delphi rounds were completed, each with 100% response rate. After the first round, 2 items were deleted, 1 item was added, and 9 items underwent wording changes. After the second round, 3 items were deleted and 4 underwent wording changes. And after the third round, no further changes were made. Chromebox Alpha for the third round was 0.913, indicating high internal consistency, and so we determined that consensus was achieved. The resulting scoring rubric contains 7 items reflecting the domains of quality of study aims, general methods, data collection, sampling, data analysis, writing quality, and strength of conclusions. Interclass correlation coefficient for the total rubric scores during piloting was 0.788, indicating good agreement. So in conclusion, we developed a scoring rubric to assess quality in qualitative medical education research abstracts with supporting validity evidence using the modified Delphi technique. Application of this rubric demonstrated high reliability during piloting, and our hope is that this rubric can aid in the abstract selection process at scientific meetings. Thank you.
Hi, I'm Dr. Calvin Huang.
I'm Christina Marone.
We're members of the Division of Emergency Ultrasound at Massachusetts General Hospital, and we'll be presenting Advanced Practice Providers Learning Applications of Ultrasound in the Emergency Department survey.
Advanced practice providers includes physician assistants and nurse practitioners. POCUS guidelines are well established for other groups such as emergency medicine residents. Currently, there are no standards regarding education and training of APPs in the use of POCUS.
The objective of the study was to evaluate APP self-perceived use of POCUS in the emergency department.
This is an observational study, specifically a survey. The study subjects included any APPs working in the emergency department at 2 tertiary academic centers. It had a combined annual visits of 180,000 and a single residency program and 2 emergency ultrasound divisions.
The survey was developed using expert consensus of 3 ultrasound faculty members. It was then piloted using ultrasound division APPs. Survey topics included prior POCUS education and training, self-reported POCUS use, and for each POCUS application, we inquired regarding comfort with each application, utility regarding clinical flow, and diagnosis. We asked general questions about experiences with POCUS during clinical use, and we inquired regarding overall POCUS utility.
Here's the first page of the survey. The questions gathered information and characteristics about the respondents. Here the APPs were asked to grade their comfort level with each POCUS application. They had to evaluate the usefulness of each application regarding patient flow and disposition, as well as the utility of each application in guiding clinical decision-making. The end of the survey asked general questions about use and the preferred educational format.
Data was recorded using a 10-point symmetric Likert scale, and data was reported using percentages, medians, and interquartile ranges. Correlation was calculated using Spearman's rho. The survey was sent to 95 APPs and 59 responded for a response rate of 62.1%. 84.7% of the APPs were PAs and 15.3% were nurse practitioners.
The median years as an APP was 5, with an interquartile range between 3 to 7. The median years at the specific institution was 4, with an interquartile range between 2.5 and 6.5. 22% of APPs stated that they had some POCUS education in school. 10.2% reported they had POCUS education with multiple lectures. 11.9% stated they had classroom education with a single lecture, and 11.9% had stated some POCUS education during their clinical rotations. Majority of the APPs in the survey had reported that they had performed less than 500 POCUS studies. 94.9% of all respondents stated that they had received some POCUS training at their current job.
APPs were asked which POCUS applications they felt most comfortable with. They felt least comfortable with MSK, ocular, and abdominal. They felt most comfortable with IV access, soft tissue, and FAST. APPs were then asked which POCUS applications were most useful regarding clinical decision making. They felt that ocular, MSK, and abdomen were least helpful. They found IV access, FAST, and soft tissue most helpful. When asked which POCUS applications were most helpful regarding patient flow and disposition, they found ocular, MSK, and abdomen least helpful, IV access, FAST, and soft tissue most helpful. We evaluated the relationship between comfort with each POCUS application and the application's utility regarding decision making and found a high level of correlation with a rho of 0.84. We also evaluated the relationship between comfort with each POCUS application and utility regarding patient flow and found an equally high correlation with a rho of 0.91. ED attendings were often willing to act on APP POCUS studies with a median score of 7 out of 10. However, they often requested a confirmatory radiology or cardiology study with a median score of 8 out of 10. APPs felt that POCUS improved their overall efficiency at seeing patients with a score of 7 out of 10. They felt that POCUS improved the quality of care they could provide for their patients with a score of 8 out of 10. APPs preferred bedside teaching during clinical shift, followed by didactics with the hands-on. Course format in the classroom was the least favored format. We concluded that APPs receive most of their training on the job, which is consistent with their current educational model. We found that APP comfort with each POCUS application highly correlated with decision making as well as utility regarding patient flow. Attendings are willing to act on APP POCUS examinations but often request confirmatory studies. Targets for future training include cardiac, other procedures, biliary, and lung, as these were of only moderate comfort and moderate utility. Limitations of this study were that it was multi-center, however it was limited to a small geographic region. Our survey also included mostly recent APP graduates, which may have biased study results. There are limitations with every survey design given reporting bias. Additionally, because of need to anonymize the data, there's a chance that respondents may have submitted duplicate responses.
Future directions include direct measurement of APP POCUS use, such as using the EMR, and exploring why confirmatory studies are needed and often requested by attending physicians.
Hi everyone, my name is Vaish Warrior and I'm a third-year medical student at Rutgers Robert Wood Johnson Medical School. I'm here today on behalf of my wonderful research team to speak to you about an exciting project that we had the opportunity to carry out this past year. My presentation is titled, Assessing Medical Students' Empathy When Breaking Bad News and Obtaining Informed Consent in Emergency Medicine. We have no financial relationships or commercial interests related to this content. For some background, both obtaining informed consent and delivering bad news are essential skills for all first-year residents to have. According to Entrustable Professional Activity 11, abbreviated EPA 11, residents are expected to be able to obtain informed consent for all interactions, tests, and procedures that they order and perform. While the words delivering bad news are not specifically stated in the list of core competencies, or EPAs, both EPA 10 and 12 specifically state the importance of communicating with the patient and family to provide the relevant scientific information, ensure understanding, and demonstrate confidence to put patients and families at ease. However, medical students during their preclinical and clinical years are not provided with ample opportunity to practice obtaining consent or break bad news independently. In order to give students the opportunity to assess their knowledge and skills, as well as receive faculty feedback in this arena, we created a two-station advanced OSCE that was administered to 13 emergency medicine-bound fourth-year students during a 2-week transition to residency course, which was offered in February 2020. The OSCE cases and standardized patient scripts were designed with input from clerkship directors and faculty to simulate real-life scenarios. Students were asked to break bad news of diabetic ketoacidosis involving a hospital admission and obtain informed consent for blood transfusion. The OSCE took place at the Rutgers Ernest Mario School of Pharmacy and utilized their simulation suite facilities. CAE Learning Space Enterprise, a simulation center management platform, was used for recording and evaluating each encounter. Here is a sample.
So based on the labs that we got back and the symptoms that you said you're feeling, it kind of makes sense what you're saying, that you've been a little tight, not been able to take it, because it's showing some kind of alarming numbers, something that we call diabetic ketoacidosis.
Students were assessed using the 5-point empathy and clarity rating scale. Each student was rated from 1 through 5 on 7 skills that fell under 4 domains, such as fostering relationship and supporting emotions, gathering information, providing information, and helping the patient make decisions. This 7-point scale had previously been used at Rutgers Robert Wood Johnson Medical School for assessing the communication skills of first-year medical students at their end-of-the-year OSCEs. Standardized patient evaluators were chosen as the gold standard because they were more likely to provide the patient's perspective compared to faculty. Standardized patients underwent frame of reference training using a recorded encounter prior to the OSCE. During data analysis, a mean score of the 7 components of the empathy and clarity rating scale was calculated. Student self-assessment and standardized patients' mean scores for the breaking bad news and informed consent cases were compared using paired t-tests. Inter-rater agreement between standardized patients and student scoring was calculated using Cohen's kappa coefficient. Results. Overall, standardized patients rated all students above 4 in 5 out of 7 components of the empathy and clarity rating scale for the breaking bad news station, and above 4 in 7 out of 7 components of the empathy and clarity rating scale for the informed consent station. Student self-assessment ratings were not significantly different between cases, but standardized patients' overall ratings did show a significant difference by case, with higher mean ratings given for the informed consent case than the Breaking Bad News case. In the Breaking Bad News OSCE, there was moderate agreement between standardized patients and students for 2 items on the empathy and clarity rating scale. 1, setting the stage for the encounter and making the patient feel at ease, and 2, creating a plan of action. There was no significant agreement on empathy and clarity rating scale for any of the items in the informed consent OSCE. In conclusion, firstly, standardized patients scored students above 4 on almost all components of the empathy and clarity rating scale for both cases, which indicates that minimal adjustments are needed to achieve the desired level of communication. The significant findings of moderate agreement in the Breaking Bad News case in a small sample size also supports that idea. Secondly, student perceptions of their abilities remained the same in both cases, but standardized patients were able to differentiate varying levels of empathy, suggesting that students may not always be as aware of their changes in their own communication. Here are some references. Thank you for your attention, and please feel free to email me if you would like to learn more about our project.
Hello, my name is Yvette Calderon, and I will be presenting a lightning oral abstract entitled Emergency Medicine Residency Does Not Correct Performance Inequity. With regards to disclosures, all of the authors are associated with the American Board of Emergency Medicine. Differential performance on standardized tests associated with race has been demonstrated on multiple examinations taken on the pathway to specialty certification. For example, a race-associated difference in test-taking performance by underrepresented minority students has been shown on the medical college admission test, the MCATs. This difference on the MCAT scores were correlated to parents' education and income. The factors that contribute to race-associated performance differences are challenging to quantify, but can include social factors, stereotyping, and discrimination. Conscious or unconscious biases may also negatively affect test-taking skills. Our hypothesis for this study is that any performance gap on the resident in-training examination within emergency medicine would narrow as training advanced for Black residents. This is a cross-sectional, multi-year study. We did regression models controlling for many demographics, which did not change the final conclusion. The final regression model demonstrated an association between level of training and race, and their scaled ITE score. ABEM does perform differential item functioning to detect bias within the in-training exam. We meet once a year to assess the ITE exam, and over the course of many meetings, we have reviewed over 1,000 questions, of which only 3 were eliminated. You can see from this table that there are scores for both Black and white residents, which improve every year. However, the mean score differences between Black and white residents does not change. Here you see the mean scores, 5.9 for EM1s, 5.6 for EM2s, and for EM3s, 5.8. This is a visual representation of the distribution of scores. We looked at individual level variables. The regression model chosen for this presentation is an intentionally simplified model. Though additional more complex models were created, we've left out covariates because they do not change the outcome we found. The performance gap for Black residents does not close over the duration of the emergency medicine residency. In this model, you can see the intercept for the reference point, white residents in EM1. Race is the uniform performance gap for Black residents present at all levels of training. EM2 and EM3 show performance gains for those years. The coefficient for the interaction of Black EM2 shows the unique change in performance for residents who are both Black and in level 2 of their training. Black EM3 shows the same interaction coefficient. These interaction terms are the direct evidence that the performance gap does not close, both because they are trivial in size, but also because they are statistically non-significant. In the study of the ABEM-ITE, a test-taking performance gap identified early in residency for Black physicians persisted until late residency. This finding suggests that for test-taking performance, residency might not have an equalizing effect. To deliver optimal care to a diverse population, our specialty would be well served to produce a more diverse workforce. To accomplish this goal, the specialty needs to eliminate any structural racism and racial bias in residency training and board certification. Residency education and early professional development should optimize learning in such a way as to close any identified gaps. ABEM is committed to a more detailed study to examine test performance of the ITE exams that involve race, ethnicity, gender, sexuality, age, and site of training. A longitudinal analysis of ITE performance will provide a more accurate analysis of individual performance over time.
I'm Aaron Fleming. I'm one of the authors of this abstract. This is identifying gaps in third and fourth year medical student rotations in emergency medicine due to COVID-19. Authors are Matt Turner, myself, Dr. Sharon Kim, Dr. Kristen Delfino, Dr. Robert Tennell, and Dr. Richard Austin. So I have nothing to disclose. I have no conflicts of interest in relation to this program. So as many of you know, in early 2020, following AAMC guidelines, medical schools across the country canceled clinical rotations for their third and fourth year medical students. Because of this, there was a need to evaluate the potential gaps or delays in the clinical education of these students that were no longer allowed in the clinical environment. What we did in this study was a retrospective evaluation of anonymous medical student logbooks from clinical rotations. We compared logbooks from third and fourth year medical students in 2019 to 2020 when they were allowed back in the clinical environment, but restricted on patients they were allowed to see. And specifically, they were not allowed to see potentially COVID positive patients. Student logbook entries were divided into chief complaints seen and the procedures they participated in. A robust t-test was used to detect differences in both total and mean numbers of chief complaints and procedures they encountered. So what we found was all students in 2020 encountered fewer patients than in 2019. Specifically, we saw decreased numbers of infectious disease and musculoskeletal complaints, gastrointestinal, genitourinary, HENT, trauma, and respiratory complaints. There were, however, no difference in the procedure numbers encountered based on 2019 versus 2020. So here's a table comparing the chief complaints experienced by medical students as a whole in 2019 compared to 2020 with a statistical decrease of specific chief complaints. In this table, we compared the chief complaints experienced based on year, based on whether the student was a third year or a fourth year. What we saw was varying decreases in chief complaints based on year. We expect this is likely due to differences in chief complaints that were presenting to the emergency department based on protocols for triaging and the expectations that were given to medical students based on their level of education. When we corrected for the decrease in emergency department volume that was being experienced in 2020, what we found though is that there was statistically significant decrease in respiratory complaints only. When corrected for the decrease in volume, there was no difference in chief complaint encountered by any other chief complaint. So what we found overall was that medical students were experiencing fewer patients during the pandemic. Specifically, respiratory numbers were decreased, which is one of the core components of emergency medicine. So limitations of the study. There's a recall bias. While some students do fill out these logbooks on shift, many of them will fill this out after shift or the next day as their time allows. There was also limitation in the method of documenting patients. As we know, many patients present to the emergency department with multiple chief complaints. So there's a limitation based on how a particular student will log the complaint that they view as the primary chief complaint. And there's also errors in documenting patients that the students did not actually encounter. What we did encounter was 1 to 2 students that were logging patients that they did not encounter, but rather just discussed with the attending physician. They're not typically logging these patients in pre-pandemic years, but we found that because they were not seeing respiratory complaints, they were discussing with the attending and then logging them as encountering that patient. We're unsure the full extent of this, but we do theorize that it was happening with multiple students that we're just unsure of. So overall, students are encountering fewer patients. Specifically, they're encountering fewer respiratory complaints, which is one of the core complaints of emergency medicine. In future pandemics or in any times where students are not allowed in the clinical environment, they may need alternative learning methods to fill in some of these gaps that they are experiencing. So at this time, I'd like to take any questions.
Hello, my name is Grace Hickam, and I am a current clinical instructor and medical education fellow at the Virginia Commonwealth University. On behalf of Dr. Sally Santon and the rest of our great team, I'd like to thank our institutions, VCU, Wake Forest, UCLA, Indiana University, WashU St. Louis, and University of Michigan for their support and participation in this project. I have no financial disclosures. This past year, living in the pandemic has brought tremendous obstacles and barriers for all of us, specifically with the shift to online learning becoming the cornerstone of medical education. Given this shift, it is important to consider learning theories within this context. The background for this project is based on cognitive load learning theory. This theory refers to the amount of information processing activity or effort imposed on working memory and the relationship between this load and long-term memory. Given the amount of information learned in residency is continuously increasing, the virtual platform for learning has the potential to add cognitive load on the learner. We found that few tools exist to measure cognitive load, and those that have been developed have not been studied in their application of residency didactics. The purpose of the study is to collect validity evidence of an instrument to measure cognitive load, specifically within emergency medicine didactics. We collected validity evidence on an instrument, including a prospective observational study of this instrument. To do this, we followed Messick's framework for validity to choose a cognitive load instrument. Based on literature review, we chose a 10-item instrument by Lepic in 2013. We made a one-word adjustment on 2 of the items to better reflect the content of EM didactics. This instrument is represented in Figure 1 here. Within this instrument, there are 3 subscales. Items 1 through 3 look at intrinsic load, items 4 through 6 look at extrinsic load, and items 7 through 10 look specifically at germane load. The responses were scaled from 0 to 10, with 0 being not at all the case and 10 meaning completely the case. This is the scale that was used in the original instrument. Then a lecture was provided by an EM faculty member to 4 different residency programs via Zoom, where residents were invited to voluntarily complete the instrument. Internal structure validity evidence was analyzed using Cronbach's alpha analysis using the 3-factor subscale structure of the Lepic instrument. Evidence for internal structure included Cronbach's alpha, indicating good agreement. Subscales also performed well within this. Intrinsic load showed excellent agreement, extrinsic load very good agreement, and germane load with excellent agreement. We also performed a confirmatory factor analysis to determine the fit of each of the subscales, with both intrinsic and germane load having good fit. We did, however, find that extrinsic load showed a poor fit using all criteria. This study provides initial validity evidence for an instrument that assesses cognitive load during virtual didactics. Our data shows internal validity for both intrinsic and germane loads with poorer internal consistency for extrinsic load. Extrinsic load is an area that many instructors may want to focus on most during virtual didactic sessions. However, it is the hardest to control as it refers to the external environment. This load is minimized by decreasing distractions and focusing on optimizing the external learning environment. The instrument showed that this had the lowest internal consistency and weakest validity evidence in our sessions. One potential reason for this is that external distractions can significantly impact this type of load and not be controlled for, given that learners are viewing the lecture in different locations rather than all in one location, as would be the case with in-person didactics. Additionally, the specific wording of the questions within the instrument may present ambiguity over the meaning of terms, instructions, or explanations, which may have affected the internal consistency. Both intrinsic and germane load are potential areas that instructors can focus on to enhance learning outcomes. These can be attended to by building on prior knowledge of learners, presenting material in a natural sequence, and by using efforts to organize materials in groupings to aid in the formation of long-term memories. While we do feel that this instrument does provide good internal validity, we do have some limitations that I would like to address. We only looked at a single lecture without a poor quality lecture to compare to. Many of the residents evaluating the lecture also knew the faculty speaker, which potentially may have biased the evaluations as well. For future work, we would like to continue examining the validity of this tool by applying it to a variety of lectures of varying quality to determine if the tool can be used to differentiate between a high versus low quality lecture. We also look to potentially investigate whether this tool can be utilized to evaluate cognitive load optimization strategies, and if this then can be used as an evaluative tool to speakers as a means to provide improve quality of future lectures by providing important feedback to help guide instructors on their didactic activities to help maximize learning and minimize cognitive load. Here is a list of our references that we used for this study. And thank you for listening to this brief abstract, and I look forward to answering any questions that any of you may have.
Thank you for this opportunity to showcase our work. My name is Ali Alvarez, and I'm an APD at Stanford Emergency Medicine, focused on DEI efforts. Relevant to this presentation, I also serve as the co-chair of the ASAP-EMRA Diversity Mentoring Initiative, which is the largest mentorship program for those underrepresented in emergency medicine. I'm excited to share our work to improve diversity and representation at the Stanford Emergency Medicine Residency Program. Our objective was to develop and assess the feasibility of a structured residency interview selection process that intentionally aligns with the department's mission, vision, and values for a more authentic, holistic application review aimed towards advancing diversity, equity, and representation in residency recruitment. The Stanford School of Medicine and the Stanford Department of Emergency Medicine are committed to advance representation in our workforce. Over the years, and with the leadership of our chair, Dr. Andra Blomkans, we have been intentional with our recruitment efforts of faculty from diverse backgrounds. The Stanford Emergency Medicine Residency Program aligned our efforts with the institution and with leadership supports to also improve diversity and representation among our trainees. EM programs review an average of 969 applications annually, limiting the ability to perform a holistic review of each application. Many programs use bottleneck criteria such as the USMLE Step 1 and 2 scores, which further introduce bias. The COVID-19 pandemic posed specific challenges to recruitment, including delays in Step 2 scores, cancellation of Step 2 CS, lack of away rotations, and the virtual interview process. We recognize the impact of these changes, specifically towards students from institutions without their home EM residency programs. And all of this includes the historically Black colleges and universities. This year, in an effort to be more deliberate in equity and representation, our residency leadership developed the DEI Recruitment Task Force. This included faculty traditionally not part of the main residency leadership to provide perspective from diverse non-medical education faculty. This group met weekly leading to the interview season to discuss, develop, and implement strategic redesign of our screening and selection process. As mentioned, bias exists in several bottleneck metrics such as the USMLE tests and membership to the AOA. This year, we made the USMLE Step 1 score solely pass-fail. Furthermore, we did not allocate extra points for those who get inducted to the AOA since we already account for this in their class ranking. Programs with no internal class ranking, of course, created some challenges. In order to minimize the impact of bias, we had one faculty review all candidates from the same program so as to develop a better understanding of their grading rubric. Because the Stanford School of Medicine emphasizes value of the ranking of the candidate's medical school, in an effort to provide equity, the Stanford Emergency Medicine Residency Program allocated the same points afforded to the top programs to candidates coming from HBCU programs. Our department also publishes our mission, vision, and values. Our interview selection process developed a screening rubric that awards points specific to efforts aligning to these values. We revised our rubric to authentically prioritize these weights for each domains. And we were meticulous in combing through every individual application in search for these points. Furthermore, during the interview day itself, we have implemented a multiple mini interview format with each candidate being asked the same set of questions relevant to key mission, vision, and values. Our faculty are also given criterion reference for scoring to minimize bias. It's important to note that for years, for the purposes of generating our interview offers, we have blinded our reviewers to the candidate's picture and other demographic data such as race, ethnicity, and gender. The structured process that we have implemented at the Stanford Emergency Medicine Residency Program focuses beyond bottleneck metrics and provides the blueprint that is a more authentic, holistic review aimed to mitigate bias in the recruitment process. Moreover, the structure of our interview process reinforces our efforts to align with the department's mission, vision, and values, and this creates the space to truly humanize our candidates in our search for our next family members. Objectively, here are some numbers. Well, our applicant pool increased from 875 from the previous year to 992 this recruitment cycle, an increase by 13%. 221 of the applicants self-reported to be underrepresented in medicine as defined by the AAMC, which is an increase from 164 candidates the previous year, or an increase of 21%. Another way of looking at it is that while we increased the number of applicants we offered interview by 83 candidates, 37 of the new spots, or 45%, were underrepresented in medicine. To the extent that we have control over our selection process, we are proud to have matched 4 URM of the 15 this year, and shows a steady increase from the past 3 years of dedicated efforts to improve representation. I'd like to conclude this key takeaway points. Our group did not significantly increase our duration and intensity of our screening process, despite the increase in our application pool, highlighting the feasibility of our holistic review efforts to improve diversity, equity, and representation in our residency program. The Stanford Emergency Medicine Residency Program will continue to refine our rubric to reinforce our commitments to aligning to our department's mission, vision, and values, including diversity, equity, and inclusion. Thank you for your time, and I welcome any questions you may have. Feel free to also reach out via social media beyond today's
Hello,
Q&A.
everyone. My name is Stephen Villa, and I'm a second-year medical education fellow at UCLA. And today I'm going to be talking to you about our study, Improving Musculoskeletal Radiology Instruction Using Online Modules, a pilot study. None of the authors have any conflicts of interest. So why do we care? Well, radiology is not taught in a standardized manner in medical schools, and its instruction is variable even in ED residencies. Rapid and accurate interpretation of diagnostic imaging is critical for patient care, especially in clinical arenas that require real-time interpretation, such as the ED. And assistance from attending radiologist is variable, often necessitating that the ED provider make treatment decisions based on their own interpretation. And this is especially true when it comes to x-rays. A recent survey of EM attendings found that only 30% felt prepared to independently interpret x-rays at graduation. And published studies regarding the accuracy of x-ray interpretation have been variable in the literature. In 2015, members of SAEM, along with several radiology organizations, met and agreed that interpretation of diagnostic imaging was an integral skill for EM providers, and also agreed that tools to assess competency were needed. As the breadth of knowledge within the purview of EM continues to expand, residency programs must continue to identify areas more suitable for asynchronous learning, which has been shown to be effective. And online radiology tools have been previously developed, but did not focus specifically on MSK x-rays, and many online radiology curriculums exist, but are not designed with the ED learner in mind. One study recently published demonstrated that the implementation of a radiology curriculum could increase resident confidence, but did not assess improvement in interpretation skills. Therefore, our objective was to create an online emergency medicine MSK education modules and evaluate their impact on knowledge acquisition as well as retention. This was a pilot study consisting of a pre, post, and 1-month retention tests. All EM residents at a single academic training program were invited to participate. 3 MSK radiology modules that exist online were created and covered specifically the elbow, the wrist, and the ankle and foot. And on the right, you can see an example of one component of a module that's available on Academic Life in EM. Tests were developed by myself and consisted of 15 to 18 multiple choice and free text items. Tests were piloted on medical education fellows as well as a sports medicine faculty, and all tests use identical items but in different order. Learners were not given answers to the test until after completion of the study, and to incentivize participation, learners were given asynchronous conference credit. Mean test scores were calculated for pre, post, and post-delayed test administrations and were compared using a paired t-test for each module. 27 unique residents participated in this study with the breakdown as you see on the screen. Completion rates for the post and delayed tests for each module were the elbow was 20 out of 26, followed by 19 out of 26 for 73% retention rate going throughout the study. For the wrist, it was 20 out of 25 and 19 out of 25 for a 76% retention rate through the 1-month retention test. And finally, for the ankle and foot, we had a 70% of our residents that entered that particular module pathway completed the study. Participants showed a significant increase in scores from pre to post tests for both the elbow and the wrist modules, with mean improvement of 1.6 to 2 points respectively. And for context, the elbow quiz max score was 14 and the wrist and ankle were out of 18. There was no significant difference between the pre and post test for the ankle foot module, and knowledge was maintained at delayed testing. So in conclusion, this pilot study demonstrates that online modules can improve knowledge of MSK radiology, and this knowledge was maintained for 1-month post-intervention for the module, for the elbow and the wrist modules, but not for the ankle foot module. Next steps include creating quizzes that are associated with the modules and would allow for ease of implementation of program directors, such as multiple choice questions. Our study was not powered to detect differences based on learner level, but subsequent studies may attempt to investigate if these modules might benefit more junior learners, such as PGY 1s or 2s. And finally, to create more modules so that the curriculum can become more comprehensive. Thank you so much for taking the time to listen to this presentation, and I hope you have a good rest of your conference.
Hello, my name is Elizabeth Yetter, and I'm here to talk about learning themes with the greatest impact on learners, a qualitative analysis. There's nothing to disclose. Assessment drives learning and is often investigated from the point of view of teachers and researchers. However, no published research has investigated how and why assessments impact learning from the learner's perspective. This qualitative 2-part study delved into how emergency ultrasound fellows learn from assessments using a constructivist design with an inductive thematic analysis. What types of formal assessments are program directors using? And what are the perspectives of the learners about how and why these assessments are helping them learn? And are there any assessments that provide learners with more value than others? In the first part, a survey was sent to the program directors of 123 programs listed in the Society of Clinical Ultrasound Fellowships database to investigate what assessments were administered to fellows. 31% of program directors reported a variety of measures, including OSCEs and simulation, but most assessments were via informal interactions during weekly quality analysis, scan shifts, and conferences. Regarding the form malfunction, once you clicked through, you couldn't go back. Perhaps people were checking to see how long it was and were then locked out. A semi-structured interview for fellows was designed based on the survey results. All interviews were transcribed and de-identified, and the first 3 transcripts were coded independently, followed by a meeting whereupon researchers revised the interview guide to expand from formal assessments to learning activities due to the paucity of the former. The next 3 transcripts were coded, settling upon a codebook under which the remaining transcripts were coded to determine if thematic saturation was reached. Initial transcripts were recoded based on the finalized codebook for a total of 10 coded interviews at saturation. Already at the start of analysis, some codes were becoming more prominent, such as role modeling, scan shifts, feedback, and deliberate practice. Transcripts were then coded via deduce and collapsed into themes that addressed how and why a particular learning activity impacted a fellow's learning. 4 main themes emerged: role modeling, mentoring, deliberate practice, experiential learning, and professional identity formation. Hardin and Crosby described 12 aspects to being a good teacher, 2 of which were role modeling and mentoring, which was captured in the study interviews. Review of the 12 aspects and incorporation of these 2 particular aspects would make for an overall stronger program with richer learning activities if the fellows feel supported and that their faculty serve as role models for the types of professionals they want to become. For example, regarding QA review with faculty, see if we think there's anything going on, and having experts able to look at it too. I think that's where I learned the most. Conversely, in one interview, some fellows felt that sometimes their faculty were too hands-off. Quote, more often than not, were me and my fellows teaching each other. And if it wasn't for my 2 co-fellows, it would just be me as the only fellow. And I felt like we would have gotten a lot less out of the fellowship. Deliberate practice. It's our culture here to do a check-in, to identify learning goals and objectives for that shift. Then we would, as a team, identify what everybody's hoping to work on and then try to make sure that we would learn that. So well-defined goals, learner motivation, feedback opportunities, and repetition allowing for refinement are all part of this framework. For example, choosing to perfect their technique in imaging the common bile duct because they know that they're weak in that area and want to improve, getting feedback and then tweaking their technique on the next one. Experiential learning. So for example, quote, it's really the bedside teaching of learners that's the best kind of ultrasound learning that you can do based on hands-on practical stuff. Based on Kolb's 1984 learning cycle, shows how fellows may have an experience, reflect on it, process it into an abstract concept, and then try it out in a new situation. This is different from deliberate practice in that they're not necessarily seeking out a specific learning experience, but rather learning from experiences right in front of them. Scan shifts are another great time for this. Professional identity formation. Even if it's not a desirable task, the fellows saw the value and how this pushed them toward taking the role of expert. Even in this example, they weren't very excited about learning machine maintenance, but they saw how this was a part of their role and it moved them forward and towards adopting their professional identity formation. As a framework, taking Miller's pyramid and adding on is, which refers to adopting the identity of an ultrasound expert as fellows progress through their training. They know how, they can show how they can do it, but then once it becomes a part of their identity. So conclusions, no definitive measurements nor board exam yet, that's currently underway. Few formal measurements are done, few formal assessments, but scan shifts, weekly quality analysis, and conferences were the most common and greatest sources of learning. Using the 4 themes to design our assessments and learning activities would augment fellows' learning. So recommendations. Similar to an artist's portfolio, fellows may establish their progress by putting together a portfolio. Regular meetings with the program director and or mentors to monitor progress would supply the needed mentoring. Fellows can choose to work on passion projects or areas in which they are weak to make lectures and workshops as a form of deliberate practice. Their image library may come from interesting scans they encountered on shifts, which they may need for future lectures, etc., as part of their experiential learning. And they may write reflection pieces on particularly interesting areas or perhaps include their research. Each fellowship would need to establish what they see as relevant to their own portfolios. And these are some suggestions from portfolios developed by Dr. D. Conybeare and Kristen Carmody. These are my references, and thank you for your time. Have a good day.
Hello, my name is Arthur Pope, and I'm a 3rd year and chief resident at the University of Chicago, and I'm excited to share our study regarding the EM East LO and students' FERPA rights. I have no financial interests or relationships to disclose regarding this presentation or study. In 2020, there were about 3,600 applicants for 2,500 emergency medicine spots across the country. Students going into and applying to EM are largely unaware of one of the most critical components of their application, which is the East LO. And as we know, the East LO helps programs to determine who they will not invite to interview at their programs. 93% of students waive their right to view this letter, which is guaranteed for them to be able to see under the Family Educational Rights and Privacy Act, or FERPA. When thinking about this study, we were thinking if students were able to see their letter, would they be able to more thoughtfully apply to emergency medicine programs because they would understand how competitive of an applicant they were. However, to date, there's no study regarding the opinions of program directors or program leadership in regards to if the SLO will become unblinded. And so therefore, that was the aim of our study, to elucidate the opinions of program leaderships regarding students waiving their right to see the SLO. The study was conducted by sending a survey out over the CORD listserv, and we had about 104 respondents. Of those who responded, 64% were PDs and about 36% were APDs. We had a representation from university programs, community, and county programs. And we also had representation across the country with good distribution across programs. And we also had good representation of 3-year and 4-year programs. Of those who responded, 53% of those said they do in fact check to see whether or not a student waived their right to view their eSLO. And 87% of those said that if a student did view it, it impacts the credibility of that SLO that they are reading. When asked if students should be allowed to view their eSLO, only 15% agreed that they should be allowed to, with 69% disagreeing. And overall, about 75% of those said that if students were allowed to view their eSLO, it would actually diminish the importance of the SLO in a student's application. About 89% of those said that they believe that writers of eSLOs would change the way they wrote their letters if students were allowed to agree. And interestingly, though, only 42% of those who responded said that they would actually write a more favorable letter if a student were allowed to view their eSLO. So in conclusion, applicants should be aware that programs check to see whether they have waived their right to view their letter. And if they did, they should know that this may impact the credibility of that letter and the overall importance of the eSLO in their application. And that currently, PDs and APDs want to continue to leave the eSLO blinded. Thank you for your time, and at this point, I will take any questions you all may have.
Hi everyone, my name is Kevin McGurk. I'm a resident at Cook County, and my talk today is titled A Comparison of Scoring Between Resident and Faculty Interviewers. Some of my co-authors, Drs. Asma Hashim, Sean Dyer, and Mike Schindelbeck are all also at Cook County. We have no disclosures to make. So some relevant background. Interviews are an integral component of the residency selection process. That's for both programs and applicants alike. The interview experience and interpersonal skills demonstrated there are routinely cited by program directors as the most important factor in how they make their rank lists. There is, however, substantial variation across programs and specialties how those interviews are conducted, both the number of interviews, who does the interviewing, and the format and structure of the interviews. It's been looked at before what sort of concordance there is amongst interviewers, but there's less known about what the role of residents are in this process. So our study question was whether senior residents and faculty interview and evaluate candidates differently. So our methods, this was a retrospective analysis and looked at scores from the 2020-2021 application cycle, so the just completed application cycle. Each applicant that we interviewed participated in 5 unstructured interviews. They were all one-on-one, led by 4 faculty members and 1 PGY4 resident. They were assigned scores from 0 to 10, and the only exclusion criteria was incomplete data. Our analysis was performed using a Mann-Whitney U-test that was for pooled resident and faculty scores. And then consistency between interviewers was measured using an interclass correlation coefficient, specifically a 2-way mixed effect model. So for our results, we interviewed more people this year than in typical cycles, obviously a very abnormal year. There were 250 applicants interviewed by a total of 16 faculty members and 7 senior residents. Each interviewer participated in at least 30 interviews. 249 of those 250 had all of their scores recorded for a total of 1,245 unique scores. The mean score between the residents and the faculty were almost identical. The residents gave an average score of 7.1 with a standard deviation of 1.53, and the faculty gave an average score of 7.07 with a standard deviation of 1.69. Unsurprisingly, there was no statistical significant difference between those pooled scores. The reliability between the interviewers was good to excellent with a ICC of 0.91 and a confidence interval between 0.89 and 0.92. Here's what the Mann-Whitney U-test looks like plotted out. On the right side of the screen there, that sort of forest green color is the faculty interview scoring. And on the left side, the lighter blue, that's the resident interview scoring. You can see that those plots largely mirror each other. The only differences are sort of at the extremes. So the faculty were more likely than the residents to give applicants a score of 10. They also were, though uncommon, willing to give applicants scores of 2, 1, and 0, whereas the residents did not give a single applicant a score that low. So there was excellent concordance between the residents and the faculty interviewers, and I think this has a few important implications. The first of those is cost savings. So while it's an extremely expensive process, both for applicants and programs alike, to go through interviewing, a large driver of the cost for programs is faculty time. And so for programs that are not currently relying on residents to participate in the interview process, incorporating them in along with faculty as interviewers represents some potential cost savings if it affords faculty more opportunity to participate in other clinical or administrative endeavors. This also allows for residents to more directly participate in the selection process of their future peers, and I think there's some value in that. Certainly there were some limitations to this study. This is only at a single program. These were open file interviews, so each interviewer had access to the entire applicant file in front of them, both in advance of and during the course of their interviews, which does leave room for bias during the course of the interviews and can affect the scoring. And finally, this was a very, very unusual application cycle for obvious reasons, and these were all conducted using a virtual format as opposed to the more traditional in-person interview style. So in conclusion, there was excellent reliability between EM residents and faculty when evaluating applicants as interviewers. It is, however, unclear whether these are generalizable to more traditional in-person formats, and I think that warrants further study. And with that, I'll say thank you for your time and for listening.
Hello, my name is Amanda Horn, and I am a third-year emergency medicine resident at Boston Medical Center. I'm excited to share with you today a project that I developed and performed with one of my co-residents, Dr. Adam McFarland. I have no disclosures. Our project is called Escape the Trauma Room. Medical education has been pushing the boundaries of curriculum design and innovation, particularly in the setting of the limitations posed by COVID in 2020 with in-person learning. Escape the room activities that incorporate active learning through puzzles have been described in both nursing and medical student education, and more recently in emergency medicine resident education. At BMC, our residency follows a graduator responsibility model. During our PGY2 year, we are expected to run most medical resuscitations and perform critical procedures department-wide. We utilize an escape the room activity format for our rising second-year emergency medicine residents to prepare them for their new responsibilities in our department. We aim to create a fun, interactive game to help master procedural techniques and medical knowledge specific to the PGY2 role. An additional focus of the activity was to incorporate crisis resource management domains through orienting residents to the physical space of the trauma bays, managing procedural competency during high-stress situations, and developing leadership skills necessary to manage a resuscitation. 13 EM residents split into 2 teams participated in the simulating learning experience. Teams completed 3 cases, procedural simulations, and rapid-fire medical knowledge questions to gain clues and unlock the code to escape in 60 minutes. Each case involved tasks and questions in order to move on, and the teams kept track of their own clues. At the end of all 3 cases, there was a series of rapid-fire medical questions that the teams had to appropriately answer to find the final clue and escape. In order to measure the impact of the activity, residents completed pre- and post-activity surveys regarding confidence in various critical procedures, managing a team, medical knowledge, and familiarity with the clinical spaces of the trauma rooms. Case 1 was a patient presenting with a stab wound to the chest. The checklist is visualized here. For example, to recognize a hemothorax, we clicked through fast images on a laptop. The team had to interpret and report this, and then insert the chest tube. In order to insert the chest tube, we had a rib model that we used. The teams had to locate and collect all equipment necessary, verbalize the steps as they perform them, and confirm placement on a chest x-ray. Case 2 involved a patient presenting in septic shock and subsequent PEA arrest. The task focused on communication and teamwork dynamics, as well as identifying critical equipment and managing junior learners during an ongoing resuscitation. Case 3 was a penetrating trauma that arrested as a result of hemorrhagic shock, thus requiring central access. This procedure was performed on a chicken breast model developed by our very own colleagues, Dr. Sean Burns and Dr. Stephanie Stapleton. Various clues were scattered throughout the cases. Some could be found taped to equipment that was needed, some were found on the interactive PowerPoints, others were the answers to medical knowledge questions that we posed. The clues gave the number for one of our emergency department pods, where an attending was waiting on the other line to grant them access to escape. We collected pre- and post-activity data on a 5-point Likert scale, with 5 being very confident and 1 being not confident at all. Residents noted improvement in their ability to locate supplies for chest tubes, cardiac arrest, and central lines. Additionally, residents agreed that they felt more comfortable functioning as a member of the trauma team and delegating tasks during resuscitation cases. Residents agreed that the activity was enjoyable, helped them to become more comfortable in the trauma rooms, improve procedural knowledge, help identify knowledge gaps, and it should be repeated for future residents. The participants of Escape the Trauma Room activity found it an enjoyable way to improve procedural techniques and medical knowledge, orient new clinical spaces, and develop team leadership skills. This exercise boosted confidence for residents in performing critical procedures and leading resuscitation efforts. We had some limitations with this activity. First was planning an interactive hands-on session with limitations due to COVID. We were also using the trauma bays, an active clinical space in a busy trauma center. Finding ways to simulate scenarios outside of the sim center also required some innovation. New models were needed and accessibility issues surfaced. For example, opening our open chest kit for each case was frowned upon. Other limitations include replicating stress to appropriately simulate these high-pressure scenarios, as well as the absence of non-empty staff available to make the sim more realistic. There are many future applications of this project. While the activity was geared towards our Writing PGY2s, it is easily applicable to any level of training and educational objectives by changing the cases or procedures. This could also be an innovative way to perform competency-based evaluations and assess milestones. Lastly, incorporating other members of the healthcare team, nursing, pharmacy residents, and so on, would be beneficial. These are my references, and please let me know if you have any questions.